Thank you. Sorry about that. Greetings from the world of neurosurgery. I am not a dietitian or a dietary specialist, and neither is Dr. Maroon, who is my partner at the University of Pittsburgh. However, your information on ketosis and ketogenic diet has made its way to neurosurgery, and we're about the most conservative group of any subspecialty, which is surgery, and then of that subspecialty, neurosurgeons are generally more conservative. So we thank you for getting the word out, and our history doesn't go back to the 1800s, but more or less the last 5 or 6 years. But we're going to try to bring you up to date on some new applications for the ketogenic diet relative to the treatment of glioblastoma multiforme. So this is our day job in neurosurgery. You can tell which one's Dr. Maroon and which one's me over in the corner there. But this is a malignant glioblastoma multiforme. And I think just from, if you've never seen one, you can see how ugly it really is. It's a very ugly tumor in the sense that it's hemorrhagic. This is a part of the brain that basically it could have gone on for a long period of time before the patient had symptoms, doing its damage. Finally, the patient will have a seizure or some other weakness perhaps, some confusion, loss of vision, and you get the MRI and you see a giant tumor. It's basically when a patient comes into our office with this, we look at them and our heads drop down and we get very quiet because we know the end of this story. And it's a sad story. And I'm going to talk about how neurosurgeons have been hitting their heads against the wall since the beginning of time treating this, and we've really not done anything for it for decades and decades. Glioblastoma, just a little background for those of you who are not familiar with it, it's by far the most common of the malignant glial tumors. It makes up about 15% or so of primary brain tumors. It increases with age. It's more associated with being elderly, male, slightly more associated with being a male. It is lethal. As I said, it is a death sentence in today's day and age. It grows rapidly. It often has a lack of symptoms. The brain is remarkable in its ability to adapt to something in it that can be as massive as the last picture you saw. And this causes a delay in diagnosis. So as I said, whether they present with a seizure or some other focal neurologic deficit, by the time we get the MRI, it's always too late. Treatments are varied, and I'll go over what those are, the standard of care, which I'll discuss several times. But the treatments kill surrounding cells. We know chemotherapy, we know whole brain radiation, other modalities that are used have to kill a large expanse of the brain cells in order to kill the malignant cells. So the healthy cells die with the cancerous cells. And this tumor specifically is not marginated, which means it has fingers or like spider web tangles that go out into the normal brain, and it cannot be completely surgically resected. So that means despite when we're done operating, we look at the tumor bed and we see all the tumors gone, and you would think we would congratulate each other that this person is now going to do well. It is not the case with this tumor because there are little fingers that spread out past the margins that can be seen, and that will be the nidus for the next reoccurrence. However, the best option or the best potential for that patient to live longer is surgical resection. So if you're able to debulk it, you can improve the longevity of the patient to what we'll talk about as far as some average lengths of living after the diagnosis. There are some metastases associated with this, generally within the CNS, the spinal cord, but it's still fairly rare. So what is GBM? It basically is a tumor that has all the right stuff as far as being a malignancy. It's like almost indestructible. If you remember the Terminator 2, the T-1000, you hit it with all the bullets and it just came back together. And that's sort of what GBM is like. It cannot be killed with our conventional warfare. It has a multiforme grossly formation. The cells are hemorrhagic in some areas. There's palisading necrosis. There's microvascular proliferation. Genetically, it continues to mutate and change. There's DNA deletions, amplifications, point mutations. There's growth factors that keep on pumping that cells to divide. And there's also chemicals that stop that normal pathway of cell death, such that the normal cellular cycle continues and continues on until basically it takes over the brain. So the classic treatments of GBM is where what we do and what 99% of universities and major universities and hospitals across the country and the world do, and that is the use of steroids, which can reduce the brain swelling. It has no treatment whatsoever on the tumor itself, but because the brain reacts like a splinter in it, it reacts with the inflammatory process, and steroids, as you know, are a very powerful anti-inflammatory, and so that can help reduce the edema associated with the tumor for symptomatic control. We also, as I mentioned, do surgery. That's what our day job is. And the idea is to debulk it. When I say complete resection, again, because the fingers and the spider webs are out there in the normal tissue, we can not really completely resect it. Radiation therapy is a standard for the whole head, typically. There are use of gamma knife, which is a very focal beam, and recurrences that are done as well later on when there are recurrences. TMZ and other chemotherapies, however, TMZ specifically can only be used in about 50% of the patients that have this based on a biomarker, whether it's sensitive or not. And this very expensive drug associated with significant side effects in general only adds about 2.5 months to the longevity of the patient. There's numerous experimental protocols, and we're going to talk about that with the adaptation of the ketogenic diet for what's been going on with treatments of GBM. And the mean survival, despite all this, is dismal, about 12 to 18 months. So we're talking about a very short survival rate with this type tumor. And uniformly, without treatment, it's about 3 to 6 months. So it's kind of a doom and gloom scenario. So again, we've had no major advances in the treatment of GBM for the last 50 years. And I think that you've heard recently about the incidence of cancer is dropping, survivability of cancer is dropping, prostate, lung, breast, all those other cancers. There's a lot of success in that, but this is missing the beat. GBMs are not being cured. And this was brought to home by one of our colleagues, Dr. Doug Konziolko, who at that time was the president of the largest society of neurosurgeons back in 2007, who specifically challenged neurosurgeons all over the world who attended to do something about this tumor. As you can see, this is a slide that shows from 1965 to 2005 that we've only been able to add on average about 6 months of longevity. 6 months is a very short period of time. So the idea at that time was to stimulate breakthroughs in neurosurgery and treatments and really start thinking about ways that we could break out of the box. And slide further on, I'll talk about the evolution of a neurosurgeon. And basically, Dr. Maroon and myself, we thought about Doug's lecture, and we thought about the things that we were learning when we were talking about fish oil and resveratrol and other nutritional treatments, and the idea of the synergisms that you all have brought to the table relative to the ketogenic diet. And I thank Dr. Seyfried and other pioneers in this area for introducing us to this information. So chemotherapy, it's missing the target with GBM. A lot of other cancers can be treated affecting cell division, cellular movement, responses to stimuli, transcription factors, vascular supply are all being utilized on the chemotherapy world in order to kill tumors. GBM, again, like the T1000, you can keep on hitting it, but it reforms itself and keeps on growing. There are also biologic therapies that are being used, but again, one of the things that Dr. Seyfried brought to our attention, and others, many others, was the idea that we are missing the boat as far as metabolic targets. The idea of what energizes that tumor. What's the fuel? What's the battery that allows it to keep on going like the ever-ready bunny? So how is that tumor being fueled? And this slide sort of is one much better presented by Dr. Maroon, in that Dr. Maroon went through an evolution. And primarily what he learned was from this gentleman in the corner, Dr. David Sinclair. And Dr. Maroon was at a neurosurgical meeting. I was there as well a number of years ago when Dr. Sinclair, at the meetings, we generally had people come in that would occasionally talk outside the field of neurosurgery, sort of a blending of different ideas in order to stimulate neurosurgery, look in new directions for treatments. And he started talking about the idea of the sirtuin genes that he had discovered, and the idea of longevity and calorie restriction. And these things tended to percolate with Dr. Maroon and myself, finally culminating in a book which we wrote several years ago called The Longevity Factor, How Resveratrol and Red Wine Activate Genes for a Longer, Healthier Life. So this sort of, Dr. Maroon's mind and my mind were primed at that time to think a little bit about nutrition and how that might interact with things like glioblastoma multiforme. And it goes back to something that most of us are aware of, the idea of evolutionary adaptability, that we have an adaptability, evolutionary, built into us relative to our metabolism. And back on the savannas, there were no grocery stores, so we would feast when we killed something, but then when there were long periods of famine or starvation. So what happens during calorie restriction? What happens when we're on the savanna where we're not eating? Obviously, we store our calories as fat, and then we mobilize them when we're starving in order to maintain our energy. So Clive McKay took this a little bit further back in the 30s, and many of you, I'm sure, are familiar with this, the idea of calorie restriction, and this is one of the first studies that looked at it. But he was able to restrict calories to a group of rats by about 40%, and they lived 40% longer. This was a fact. How that happened was not known for many, many years until a fellow by the name of Lenny Guarini and David Sinclair got together, and they looked at yeast cells, and they decided to lower their calories, and they also found at that same time the same thing that happened with Clive McKay's rats, in that they lived longer. And they were able at this point in time, with the level of science that we had available, to actually find out why. And what they discovered was the SIRT2 genes, or as we'll talk about later, the sirtuin genes. The idea that a gene could be activated during the time of calorie restriction, and we subsequently called those longevity genes as a slang, if you will. But the idea that they prolonged longevity during that time of famine. So there were long periods of famine, and the body would actually change biochemically. There were things that were happening that actually were causing conservation of that body during time of famine. And some of those things were they were reducing oxidative stress, they were killing off dead cells, there were metabolic and hormonal changes. So all these things were happening. They discovered specifically the sirtuin genes. There's other genes that now have been discovered and other pathways that are activated during the time of calorie restriction. So calorie restriction activates the sirtuin genes, which again underlines the molecular changes that occurred during calorie restriction. And I'm sure a number of you at this point are saying, yeah, I've heard of that. As a matter of fact, I know people that are doing calorie restriction for this kind of benefit. There are actually a number of societies that do this routinely to try to activate these genes to live longer. But basically, we evolved these. It's not a causal relationship. They were evolved. And it turned out to be a survival mechanism. Again, sirtuins were able to delay apoptosis, promote cellular repair, inhibit atherogenesis, neoplasia, and neurodegeneration. So all these things were occurring during calorie restriction, as well as many other things that have been going on. And this is a slide that you might have seen before, that the idea of calorie restriction has many pathways and transcription factors that are activated in order to have some benefits throughout the body as far as preserving it during the time of famine. So one of the early studies that has taken place is the idea of looking at longevity and calorie restriction in monkeys. And some of these studies you might have heard of made the news. The monkeys didn't live any longer. In the treatment group, those that were more severely calorie restricted didn't live longer. However, they did have significant benefits. They had lower triglyceride, cholesterol level, fasting blood sugars, and they also had a delay in age-related diseases. So there were benefits relative to oxidative stress and other factors. They did not necessarily statistically live longer than the controls. Now, whether a monkey in captivity, by the nature of the captivity, is going to sort of live similar amounts, even if they're calorie restricted or not, is one of the controversies with this study. There was a recent review in 2011 that looked at human studies that had looked at calorie restriction, and they found significant alterations in energy metabolism, reduced oxidative damage, improved insulin sensitivity, decreased inflammation, and numerous functional changes within the neuroendocrine system. So the idea is there are benefits, proven benefits with calorie restriction. So what happens when we're starving? And I'm sort of the appetizer. There'll be numerous lectures tomorrow that'll really go into the heavy part of the use of the metabolic changes that occur in when you're fasting in ketosis and tumor growth and restricting tumor growth. But as you can see, we can mobilize free fatty acids to make ketone bodies, which are subsequently being able to be used by the brain. So the brain uniquely can use two energy sources. It can use glucose, or in a time of famine, lack of significant amount of carbohydrates, it can switch over to a ketone-based energy source. The point is, this goes back to Dr. Warburg, who's told us a long, long time ago, the idea that cancer is a metabolic disease, the disruption of energy metabolism. That cancer can live in an anaerobic environment. It cannot live without glucose. So it cannot use ketones. Versus tumors, which can use, versus normal brain cells, which can use both ketones and glucose. And that's really the point of what Dr. Seyfried and others have said, that the idea that uniquely tumors, and specifically GBM tumors, as well as most other cancers, cannot use the ketone bodies as an energy source. They have to have glucose. So again, what happens in calorie restriction? We lower the blood sugar. We lower the fuel to the tumor. Going back to Dr. Diamond's lecture, I agree with you. Sugars are bad. And this, we know, not only is it bad for us, it's bad for us developing the risk of cancer or having cancer. We know that those with type 1 and type 2 diabetes have an increased risk or incidence of mortality, as well as site-specific cancers. So the idea that in and of itself having hyperglycemia is a risk factor relative to developing cancer. Persistent outpatient hyperglycemia is independent and associated with decreased survival in primary section of malignant brain astrocytomas. So again, back to brain tumors itself. If you have hyperglycemia, you're going to have a worse prognosis if you have a brain tumor. So think about the cancer wards in America. What are the things that they're feeding people that are having chemotherapy and other cancers? Sugar. Let's have some ice cream, you're not feeling well. Let's have a candy bar, maybe you can keep that down. The idea of hyperglycemia is rampant within that time frame, which is probably the poison or the fuel that's causing these brain tumors and other types of tumors to grow. Going back to the idea of sugar, in the savannah back in 10, 20, 30, 40,000 years ago, we ate very, very little sugar. Carbohydrates were almost unheard of as far as naturally occurring. 1830s, we increased it. By 2015, we're eating up to 150 pounds of sugar. So we're overloading right now with sugar. Sugar is growing brain tumors. So here are the facts. Human calorie restriction, starvation, we know it improves metabolic functions. It lowers our fasting blood sugar, improves insulin sensitivity, but it's hard for people to do. Has anyone ever done a significant calorie restriction a couple days? No, you guys, neurosurgeons would never do that. And if they do it, like Dr. Maroon did, he got very cranky. So what happens during human calorie restriction or starvation? We mobilize our free fatty acids to make ketones from the liver. We know that ketones are an alternative energy source for the brain. Brain cells, cancer, or other type of cancers, evolutionarily are younger than our cells within the human body. They exclusively metabolically use sugar for their energy source. Excessive levels of glucose, such as those people with metabolic syndrome and diabetes in our Western diet, enhances our cancer risk and mortality and morbidity. So what do? This is Dr. Seyfried's from his book, and a wonderful slide that he puts here where he talks about all the things that we do to treat brain tumors actually are stimulating more tumors. So we're giving radiation, which is inducing oxidative stress, and we're breaking down neurotransmitters, which are toxic to the brain. We're increasing the blood sugars with decadron, which increases the amount of sugar in our body. All these things are the exact opposite. Basically, what he co-authored a paper with us, we're adding fuel to the fire. So our current standard of therapy is adding fuel to the fire for a typical brain tumor. And you can see here, these different areas where are coming in and causing worsening of the patient rather than better. So this is one of Dr. Seyfried's earlier papers talking about animals. This past year we wrote a paper that talked about all the new human studies that are now being done using calorie restriction and ketosis for human cancers. There aren't many of them. As I said, we're talking about maybe 10 years worth of history. We're in our infancy. This is just starting up. More and more information is going to be coming, but right now we're very low on the information, but we hope to gain more. Glutamine is a normal neurotransmitter in the brain. However, when released extracellularly, it can become toxic. So radiation, chemotherapy, the surgery itself releases this neurotransmitter, can cause significant problems with normal brain tissue. Other inflammatory cytokines are released, again, glucocorticoids stimulating the increasing amount of blood sugar, which again is feeding the tumors. So again, this is from Dr. Seyfried's, one of his articles, the idea of managed growth. We want to increase the ketones, lower the blood sugar in order to maintain a managed growth of that tumor, to slow it down. This is a friend of ours, actually from the University of Pittsburgh, his mother, Giulio Zaccoli, who placed his mother on a ketogenic diet for approximately about 2.5 months. And the top, you can see the brain tumor, and the bottom, you can see it's gone. So this really stimulated us to get the ball rolling, and many others within the field. He wrote this paper back in 2010. We have another article here that talked about the use of ketogenic diet in multiple different types of cancer in 16 patients from Europe. This was a paper that was recently released from our colleague, Dr. Schwartzen at Michigan State, who did 2 patients. And one of the things I like to point out in the title, IRB approved. This is very controversial for IRBs and treatment. There's a standard of care, radiation surgery, chemotherapy, use of decadron. To not do that, this study was done on patients who had failed treatment. And as you can see, they had fairly poor results. To place someone on a ketogenic diet is difficult in and of itself. They were already late stage. They did not have any significant change in the size of the tumors with this. So right now at the University of Pittsburgh, and Dr. Champ tomorrow, who's the one of the keynote speakers, will discuss a study we're going to do at the University of Pittsburgh, trying to lessen the burden of calorie restriction by using 2DG. It mimics glucose, can lower the blood sugar, hopefully cause a little bit less torture to the patient by reducing the amount of glucose level, but allowing them to have a little more carbohydrates. And this is a study we're going to be doing here shortly, hopefully in the spring of this year. So I didn't have much time, but hopefully you caught a little of that. Do I have time for 2 questions? Any questions? Yes. Hi.
Hi. Nice talk.
Thank you.
Actually, it's not a question, it's a comment, and that is that in terms of the calorie restriction, while the IRBs get very, very upset about that, some of them do anyway, when you're working with a registered dietitian that's working directly with the patients and following glucose and ketone, very often the patients are calorie restricted, but it's because that's what it takes to get the ketones and glucose where they need to be. But you don't have to say that because it's not like every patient is reduced to 80%, and that makes everybody happier.
Good point. One more question.
You don't have to subtract from the questions. I have a comment. I have an anaplastic astrocytoma, and I know many people that have PBMs, and we've had very high success making a decision to transition to a very high-fat diet, low-carb diet, ketogenic diet, in fact. As a patient, I think that more needs to be done in terms of sharing research with patients, especially in metabolic therapy. So I really applaud this conference for that. But and I do agree that the standard of care really does put fuel on the fire. However, I think it's also important to note that I know many people have had the standard of care and have done the ketogenic diet, and the ketogenic diet has actually improved their outcomes dramatically.
Well, thank you. Thank you for being here. And I just want to preface this by saying it doesn't, as you said, people can be educated and can do it on their own, certainly outside of IRBs, but we always recommend some sort of physician supervision relative to it because of some interactions that may occur. So I think it's prudent to talk to your physician, but if you have a good cooperating physician and you're willing to do it, I think it's worth it. Can I take one more?
So working in the glioblastoma realm, I'm not sure if this is where you guys are focused, but we know the IDH1 mutation, which is very common, right? Most of these glioblastomas is driving a male conversion or a misconversion to hydroxyglutarate. I'm sorry, alpha-ketoglutarate to 2-hydroxyglutarate, which we're now finding is an oncometabolite. So you can take this molecule, 2-hydroxyglutarate, and literally put it on non-metastatic tumor-like cells and convert it into metastasis. And it turns out we just discovered it in breast cancer as well, a few other cancers, even though they did not have the IDH1 mutation. So it kind of maybe bodes to the concept that maybe this type of ketogenic diet would push that pathway in a different way and walk away from war metabolism to something else and not produce that. We call them oncometabolites. Have you seen anything along those lines?
I can't say I have, and Dr. Seafried may be able to comment on that at his lecture, but I'm not familiar with that.
Thanks.
Okay.
Can I just jump into this just to answer his question? So this IDH1 mutation is what it causes, it's called a reductive carboxylation. So mitochondria start reversing and producing fat from glutamine and from carbohydrates. And interestingly, shutting down this IDH production does not necessarily have any for the patients. If you look at NGO's clinical trial, they just failed. So obviously these genomics are not as efficient as disease drivers, as unfortunately patients and physicians think. What this reaction, therapy reaction does is ketogenic diet depletes glutamine, which is a epigenetic oncoisotope. So from oncometabolites, we're going to oncoisotopes, which actually make these efforts more clear and clarified as far as how metabolism connects with this genomic oncometabolites and oncoisotopic stories that I'm going to talk about this tomorrow. But unfortunately, the genomic scenario, if you draw it up, is really not very efficient. So medicine has to change in that direction. And we're going to talk about this.
Look forward to it. Thank you.